Everyone to our geriatric echo webinar. My name is Sarah Tomkison, and I'm a social worker and member of the Geri Echo Hub team. I want to again recognize that one of our sponsors for this CME activity is the Queen's Medical Center, along with UH's Jebsum Department of Geriatric Medicine. Joining me this afternoon on our interdisciplinary geriatric ECHO team is Dr. Rita Bell Fernandez. Other members on the team but aren't able to join us this afternoon are Courtney Nuno-Kawa, nurse practitioner, Mr. Chad Kawakami, pharmacist, and Dr. Lucas Morgan, our psychologist. As a reminder, if you do want to get CMEs or social work CEUs, you can find the evaluations on the link in the chat or at any time on our website and email advertisement. We are currently offering continuing medical education for physicians, DOs, RNs, nurse practitioners, and physicians assistants. And as I mentioned earlier, we also offer NASW CEs for social workers and certificates of attendance for certified nurses aides and students. Your comments are very important and useful for us as we plan future programs. About the ECHO, we want to emphasize that this webinar serves as a forum for mutual teaching, learning, and sharing from our experts and also from each of us on the front lines. As the ECHO motto saying goes, all teach, all learn. So it will take all of us to create a community of learning. As a review, our ECHO webinar the format consists of the presenter giving a brief overview or short lecture. Then we welcome open comments from the experts on our hub team. And then you, the attendees and participants, we really invite you to ask questions. Provide us your comments and examples of case discussions. Additionally, we invite you to share any geriatric cases. And lastly, we just ask as a friendly reminder to please keep those case discussions HIPAA compliant. And this includes not sharing the patient's name, birth date, address, and so on. We learn best from our patients and our clients. They are our best teachers. Now it is my pleasure to introduce to you this afternoon our distinguished speaker, Dr. Rita Bell Fernandez. She's an associate professor at the Geriatric Medicine Department of the John A. Burns School of Medicine with the University of Hawaii. Dr. Fernandez is a practicing geriatrician with Kali'ipalama Health Center and also an associate medical director at Islands Hospice. She graduated from medical school in India in 1995, moved to Hawaii in 1999 to study geriatric medicine at the University of Hawaii. Dr. Fernandez has served on the Doctors Work Group for the State Task Force on Alzheimer's disease and related dementia. She was the co-principal investigator of the Hawaii Alzheimer's Dementia Initiative. It's a grant from the Administration of Community Living. She has championed memory clinics across the state to provide comprehensive dementia care to our kopuna. She's also a certified master trainer of the National Group on Intellectual Disabilities and Dementia Practices curriculum. Welcome, Dr. Fernandez.
Thank you, Sarah, for the kind introduction. I would like to begin by addressing Melissa's question from KKV. Hi, Melissa. I too have been doing evaluations and I've received nothing as well. So just like you, I'm doing evaluations and I get nothing. And then it takes me back to how does Queens do their CME? Typically, I've participated in many Queens activities and I have privileges at Queens. So usually it's at the end of the year you receive for the whole fiscal year. They'll tally all the Queens CME activities that are done, but we will follow up with them again and see if that is still their practice, or are our attendees really missing their CME credits? So thank you for bringing that to our attention. I will certainly follow up with Queens on the issue of people not receiving their CME certificates.
Dr. Fernandez, I just wanted to add, we do have registration. We have a record of all participants that have registered, and with that, we also have a record if you've completed the evaluation.
So Melissa, rest assured, you have our guarantee. You will get the certificate. Maybe it's not coming on a monthly basis. Maybe it will come at the end of the year, but you will get the CME credits for all your attendance. And thank you very much for participating. We appreciate the FQHCs joining us. Thank you to all our other attendees. So today's talk is on dementia in a very different subgroup. I will not be talking about the elderly. I'm going to be talking about a different population, adults with intellectual and developmental disabilities. These slides are the slides from the NTG, which is the National Task Group on Intellectual Disabilities and Dementia Practices. So who is the NTG? They're a coalition of interested persons and organizations, and their mission is to ensure that the needs of adults with intellectual and developmental disabilities who are affected by Alzheimer's disease are taken into account as part of NAPA, which is the National Alzheimer's Project Act. And I will tell you, it's so impressive. Their advocacy is so strong that anybody who gets federal grants today for dementia has to address this population. So whether Catholic charities, University of Hawaii receive monies, every grant has to do something. And we have brought the NTG training to Hawaii as part of our Hattie grant in 2016, and they will be coming again in November of this year. So another opportunity, if you wish to become a trainer, a regional trainer, it's November 1st, 2nd, and 3rd. At Queens, more information will be sent out by Jody Michon. So let's look at the risk of dementia in persons with intellectual disabilities. They are typically no more at risk than the general population. However, adults with Down syndrome are at increased risk. They tend to be younger, and they tend to have a more rapid progression. Now, in intellectual disabilities, it kind of mimics the general population. However, in Down syndrome, you see by the time persons are 60 years and over, more than half have dementia. What is the prevalence in the general population? It's estimated 1 in 9 seniors over the age of 65, and 1 in 3 seniors over the age of 85 have Alzheimer's disease. And the number is projected to increase and probably reach 13.8 million, if not more, by 2050. Now, what about in Hawaii? What are the numbers of Alzheimer's disease in Hawaii? We think the number is around 35,000. However, this is greatly underreported because we don't have accurate data. If you look at a lot of charts, many people may just have the ICD-10 of forgetfulness. I see a lot of forgetfulness, but I don't often see the ICD-10 for dementia or a particular type of dementia. So what we are really seeing is just the tip of the iceberg. Our figures are not including all those who are undiagnosed. And guess what? Nearly 60 to 80% go undiagnosed. There's a whole multitude of reasons. Families don't know what is normal. They think grandma or grandpa is just getting old, or they think the person with intellectual disabilities or developmental disabilities, they're just, they're moody, they just want to be in their room. So families are struggling. providers have very limited time in a 15-20-minute appointment. Most of our time is taken managing diabetes, blood pressure, making sure people get their flu shot. That stopped for September. So, you're caught up in all of these different HEDIS measures that dementia is often forgotten, especially if the family doesn't even bring it to our attention. So let's do a little refresher. I know many of you know this, but we'll go over what is Down syndrome. It was first described by English physician, Dr. John Langdon Down. It's a developmental disability having both intellectual impairment and physical abnormalities. We commonly know Down syndrome as trisomy 21, and that's because they have 3 extra sets of chromosome 21. And many of you, when you see a person with Down syndrome, you can often recognize it because they have very common physical traits. This is an example of chromosome 21. It's the karyotyping showing they have 3 chromosomes. And Alzheimer precursor protein, the amyloid precursor protein is actually found on chromosome 21, which is why they tend to have a lot of beta amyloid in their brains. So we also see premature aging in Down syndrome. The life expectancy has continued to increase, and they have developed all of the aging risk, but at a much younger age. So they are aging in their 50s. They're at risk for diseases and changes about 20 years earlier. So they get heart disease, osteoporosis, and things that you normally think of in the elderly at a younger age. Now, why are we focusing on Alzheimer's disease? Because in the dementias, it's the most common type of dementia, and Alzheimer's presents differently in Down syndrome. So how does it present? It presents with maybe seizure activity when there has been no seizure activity in the past. It may present as incontinence when the person has always been independent for toileting. The short-term memory loss may not be such a classic hallmark like we see in our elderly population. The short-term memory loss depends on their baseline, on what was their previous level of memory. Families may commonly see sleep-wake cycle disruptions. So it's unpredictable and it's unique to each individual. Dementia affects all aspects of functional ability. It affects memory, language, reasoning and judgment, sensory perception, also ability to sequence tasks. Now, the challenge we have in this group is that the traditional screening instruments for detecting dementia are not useful for persons with Down syndrome. So the ones that we're familiar with, like the mini-cog, the MMSE, SLUMS, MOCA, all that is not useful. So there is an alternative screening tool, which I'm going to discuss today. And John, if you would so kindly put that in the chat so everyone has access to this PDF attachment and can follow along on their computers. Thank you, John. So what is the EDSD? NTG developed this it stands for Early Detection Screen for Dementia. And it was based on 2 earlier screening tools. It was based on the DSQIB and the dementia screening tool that was developed earlier. And it is advised that we begin this at age 40 for persons with Down syndrome. However, some are recommending to start earlier than 40, to maybe start at 35. For non-Down syndrome, you can begin at age 50. And this tool has been translated into multiple languages, and it is available on the NTG website. So pages 1 and 2, it's a 6-page tool. So this is something I need to tell everyone. I know we're used to 1-page stuff, right? MMSE is 1 page, SLUMS is 1 page, but this tool is 6 pages long. It can be used by support staff, by the caregiver. It doesn't have to be filled up by a medical provider. So pages 1 and 2 are basic information. Pages 3 and 4 go into the functional status in their functioning and areas associated, problem areas with dementia, their sleep, their mood. Page 5 is coincident conditions, comorbidities. Page 6 is the medications and comments and further action plan. So these are the 4 key sections: demographics, rating of their health, mental health, and life stressors, review of multiple domains, which includes the activities of daily living, language and communication, sleep-wake patterns, ambulation, memory, behavior and affect, and their chronic health conditions. So who can complete this form? So I'm not requesting any of our physicians and nurse practitioners, because we know you only have 15-20 minutes, maybe 30 minutes at an appointment, and to complete a 6-page screening tool may be too much. So caregivers can fill this out. Service providers, many persons with developmental disabilities and intellectual disabilities are enrolled in daycare, in day health. They go to different programs, and they may be with a DD waiver provider. So example, ARC, Easter Seal, SECO, these are all the waiver providers, and they can also fill out these forms, the supervisors, the case managers, the PAB workers. If they know the client, if they're familiar with the client and they have known them at least for a minimum of 6 months, maybe they have access to the chart, then that person is suitable to complete the form. And it is using their best judgment. Where do you get the information? You can speak with family members, with staff who know the patient. You can look through the medical records, through their program files. You can ask the person who's being screened. You can also speak with friends and close relatives. Another useful tool that the NTG recommends is taking short digital video of a person performing certain tasks, like say putting on your shirt. Be interesting to see how putting on their shirt changes over time, because often a person who is very capable of doing this may later show decline in just a simple activity of daily living. What happens next after you have completed this form? Review the form, see if there are any changes of potential concern. Because maybe there's no concern, maybe you think, oh, the person is depressed because this and this happened in their lives, so they need to be treated with an antidepressant. Maybe it's not dementia at all. Speak with the case managers, the key workers on the team, and if necessary, then if you're concerned about an abnormal screen, then make an appointment for the person to be further assessed. Another interesting point, if you're looking at these 6 pages, you will notice something. The first thing I thought when I saw it the first time, I said, where is the score? Where are the points? Because we're so used to giving points. You know, every tool we use for dementia screening has points. This particular tool does not have any score. So there is no pass or fail. There is no number to determine who has passed and who has failed. So how do you make sense of this tool? Essentially, the person is graded against their baseline, against how they performed last year. So one person with Down syndrome is not compared to another person with Down syndrome. They're compared to their own baseline and changes over time. So what else will you do as part of the dementia workup? Please rule out delirium, you know, your 3Ds, delirium, depression, dementia. So in persons with DDID, you want to look for, is there a significant life event? And that is noted in box on the second page in box 14. You'll see, has there been a death? Have they moved, locations? Maybe they've been transferred from one care home to another care home. Look at all those things because it may contribute to anxiety or depression and may have nothing to do with dementia. We need to review medications because so often persons are having side effect from medications. There are too many doctors prescribing medications. Patients go in and out of hospital, emergency rooms, urgent care, and the list changes again. So medication review at every visit is very useful. History and physical exam and lab tests. And one of the lab tests that they recommend, which we don't have in the typical elderly workup for dementia, is screening for celiac sprue. And MRI and CT scan if possible. Often it's impossible. Even blood test is it's very hard. I've had real challenges in doing blood tests with this population. So the 3Ds, as I mentioned, dementia is gradual. It's over months to years. Delirium, on the other hand, is very sudden. There could be an infection, there could be COVID. A person is having confusion, memory loss. All of this is sudden over hours to days. Depression can be over weeks to months, and unexplained change in mood that may be associated with forgetfulness that you notice over weeks. If you do a CT scan, what will you see? You'll see the hippocampus is shrunken. Look at the red, blue, and green areas. That is the hippocampus, the memory centers of our brain that is smaller. There is cerebral atrophy. So you see on the right-hand side, there is more cerebrospinal fluid. What about medications in this population? The NTG does not particularly recommend medications simply because very little to mild change or improvement have been seen in this population. Though the drug is approved for moderate to severe dementia like Namzaric, you can do that. You can also open the capsule and sprinkle it on the food. So this is a trial and error. Either it works, it may work, and you may see a better result for the behavior. Some of the anticholinergic might help improve the behavioral symptoms. So remember, as a provider, you are in a position to be a health advocate. We are urged to give voice to the voiceless, especially in this population. We need to think about advocacy because we may be that responsible person. We may work with the team. We may be a friend, a relative, and whatever capacity the person is involved in, you can help, whether as a nurse, a social worker, a provider. All members of the team can help the person with DDID. So I will end with the importance of healthcare advocacy. Remember, healthcare is an art, not a science. So please do your best to champion this population. I'm happy to take questions, and I hope everybody has access to this file and is able to open the attachment.
I have a question, Dr. Fernandez.
Yes.
Can you share with us with regards to this NTG screening, the early detection screen for the dementia? Do you know if this is being adopted by the State Department of Health or Developmental Disabilities branch in particular?
Thank you very much for that question. Yes, in 2016, when NTG was brought to Hawaii, the training was held at the Queen's Auditorium. We had nearly 40 staff. It was sponsored by the DDD department as well, and a lot of the case managers attended. And this time again, I'm wondering whether Jody has joined us, because Jody can share most updated information as to what's going on in the state. But yes, the DDD department is aware of the tool and is encouraged to use the tool. The challenge we have is that since we brought this training in 2016, the adoption of this tool is very low, simply because there are other things they do to assess function. They do the CIS, the ICAP. So the service providers are doing other scales and other tools. So sometimes they feel, is this repetitive? Like I already did it in this other section. So now with the Catholic Charities grant, our focus is to reach out to the caregivers, to the family members, to see if they could be the ones to fill out these 6 pages and bring it to the attention of the provider. And my role in sharing this today is that you are at least aware that a tool like this exists. Because if somebody filled the 6 pages and put it in your hand, Sarah, you should not say, what's this? I've never seen this before.
Yeah, this is so educational because I didn't know that such a tool existed. But you bring up those excellent points about reaching out to caregivers because I think that might improve the underreporting challenges that you presented earlier. I think it's, yeah, most of the persons with intellectual and developmental disabilities, they're being cared for by their aging parents. And I wondered if anybody in the audience is actually seeing clients who, as they're aging, are having their own health challenges, and they don't really know what to do for their adult son or daughter. Um,
I would like to share, since I have some time, Sarah, I have some additional slides because through the Catholic Charities grant, we have Judy Takeda here from Catholic Charities. Thank you, Judy, for joining us. Catholic Charities has really championed this effort, and we have brought the NTG trainers, especially to come to Hawaii and present to DDD, to ARC of Hawaii, and the waiver providers. So I want to go over each page. I know I talked about the 6-page form, but I would like to, since we have some time, I want to go over page by page. Is that okay, Sarah?
Absolutely. And if people have questions at any time when Rita Bell's going over this, just put your questions or comments in the chat, and I can forward that to Dr. Fernandez.
Okay, so the rationale behind the development of the NTG EDSD. They wanted to equip families and professional caregivers with a tool to capture information about changes in cognition, behavior, and daily functioning. They also wanted to provide caregivers with a format to share information. They wanted to train caregivers to recognize relevant signs of change. And the NTG is advocating that this can be done during the annual wellness visit, the Medicare annual wellness visit. But I know you'll say, oh, we are doing so many more things. We're doing the polls, the advanced directive, we're doing so many forms. But this is one tool you could use. If you have a DDID client, you could use this in the annual wellness visit. So it can be completed by support staff, it can be completed by family members, by other stakeholders. It picks up on health status, ADLs, behavior, functioning, and other self-reported problems. It has been translated into multiple languages. So we can go page by page. How do I complete the form? So the who is anyone who's familiar with the client. Anybody, if you know the patient and you're good to go. Where can this be done? It could be done at a wellness exam. It could also be done at a daycare program. A lot of our DDID population, they go to program. A big one is Lanakila. Lanakila has a big program. What does it do? We can gather information from the chart and other, relevant medical data in order to fill up some of these medical and mental health status changes. So
Rita Bell, there's a question in the chat for you from Renata. Is it validated only for DDID, or can it be used on others? I think this is a screen.
Yeah, it's validated for DDID. So I wouldn't expand it to the spectrum of, say, autism or other areas. But right now we are trying to push it for DDID, and still we have very low adaptation of this tool. You can see if you don't have much luck with the slums or minicog, and you think, oh my God, I'm getting nowhere with that tool, and maybe no one even has written in the chart that somebody has mental retardation or just gone undiagnosed, then Renata, I would suggest if you're having no luck with one of those tools, then pull up this tool, and you can try and see if you are able to pull up more information that's helpful through the EDSD. So the cover page starts with demographics. You can see name of the patient, date, age, date of birth, all that. The next thing it's going through is level of intellectual disability, if it's known. What is the developmental disorder? Sorry, autism is on this. I mean, don't expand it to other spectrums. Like people say, what about PTSD? What about, and you can go on and on and on and try to use it for developmental disabilities, intellectual disabilities. Diagnosed condition, what is their living arrangement, if you know. Most of them are, not institutionalized. We have people living in the community, whether they're living alone, with their spouse, with their family member, with a paid caregiver. What does page 2 look like? Items 10 to 15 is the opinion of the rater. How is the person's current physical and mental health as compared to the person's health from last year? So it can be excellent, very good, good, fair, poor. What about physical health? It could be from 1 year ago, much better, somewhat better, about the same, somewhat worse, much worse. So it's comparing it to a year ago. Then you have 16 to 18 items if the person has already been diagnosed. Maybe they were diagnosed with mild cognitive impairment. Maybe they were diagnosed with dementia. Maybe the chart is just saying forgetfulness. I most often see the ICD-10 of memory loss or forgetfulness. You may not pick up MCI or dementia, but you can put all that in the comments. So box 18 is comments or explanations about dementia suspicions. Page 3 is looking at the domains, the activities of daily living, language and communication, the sleep-wake cycle, ambulation. Now here we are going through a Likert scale. So a Likert scale is a series of 4 or more items that represents range of choices. So it's going to ask you whether you agree, somewhat agree, neutral, disagree, or strongly disagree. So each of this is just a way of capturing the observation or capturing the change. And you also have does not apply. So look at page 3. You're asked a whole bunch of questions from 19 to 22 that are based on the Likert scale. Always been the case, always but worse, a new symptom in the last year, and does not apply. So where the red flags go is if it's a new symptom in the last year, then you need to pay even more attention. If it's always but worse, that's another thing to alert us. It's another red flag that maybe something is going on and we have to pay closer attention. So when we say always been the case, what do we mean by always been the case? Keenan has always needed help bathing. It has always been the case he does not initiate conversation. He always sleeps excessive amounts. So by choosing always been the case, what you are saying, you're not saying whether it's normal or abnormal. You are saying that it is usual for this person and there is no change. Do you understand? It's going to each person is unique, and that is the person's baseline. What has always been the case but worse? Now let's look at this example. Rose has needed verbal prompts to complete showering and now needs hand-over-hand assistance. Another example of always been the case but worse, Rose has mobility problems. Previously, she was using a walker, but now she's using a wheelchair. Or you could have previously was using a cane, but is now requiring a walker. She previously needed her food cut up, but now she's only eating finger food. So what happens in all these examples, you can see that it's always been the case, but now it's worse. So you're indicating that the person has lost more skills and they are less independent with an activity of daily living for which they already had problems. So essentially what you're saying is the situation has gotten worse. Now, what about a new symptom? What do we mean when we choose new symptom? Walt has episodes of incontinence that began 3 months ago. So that's a new symptom. Walt has become lost when walking home from his program twice within the past 6 months. So it didn't occur in the previous year, but now it has happened recently. He cannot remember the name of his new staff and began calling the new staff by the name of a worker who has not been at that home for several years. So what you're saying by new symptom is you are indicating that this was not a problem last assessment, but is a problem now and is a new sign of change. Let's look at does not apply. What do we mean when we choose the rating does not apply? For example, Joy does not need assistance in showering. Joy does not need assistance in dressing. Joy may have a mild episodes of forgetfulness, but this does not interfere with her activities of daily living. So by choosing does not apply, we're indicating that this is an area where Joy does not have a problem. So what is page 4? Page 4 is looking at the domains of memory, behavior, and it really gets into the behavior like wandering, hiding, hoarding, impulsivity. So there's a whole bunch of behavior, talking to yourself. Then there's self-reported problems, and there's changes noted by others. Maybe the person doesn't think it's a problem, but other people think it's a problem. So this is another way of, it's capturing it in much greater detail, because, whether people are hearing things, seeing things, that can all go in self-reported problems. You don't have to tease it out, whether it's a delusion, a hallucination, whether it's true, whether it's false, but you can at least capture it and put it down, whether they've had changes in interest, changes in their thinking. What about the chronic health condition? This is again very detailed. It goes into bones and joints, heart and circulation, hormonal, lungs, mental health, pain, sensory, and other medical conditions. So this particular page was based on the Longitudinal Health and Intellectual Disabilities Survey from University of Illinois at Chicago. So that's how they got this list. So you'll see something like dental pain. We don't often think of, we often forget our teeth and our mouth, but in a DDID population, dental is very important, and dental pain has made the list here. What about page 6? Page 6 is gathering information from the person's chart regarding the current medication. Now, you don't have to write it all over again. You can just say see attached. So that can also be fine, see attached med list. Other background information. Changes observed but not covered in the rating form. So any concerns, any notable changes, you can list all of these here. and next steps, whether the next step is to refer to a physician, refer to a clinical personnel, maybe include this in their annual review or the annual wellness visit, bring it to the DDD case manager. A lot of our patients are case managed by the state of Hawaii. And it's very interesting that even when we had this whole Quest integration and Quest expanded access, there's one program that never merged into all of that, and it still retained its waiver status. We lost everything. Nursing home without walls, everything got merged into Quest expanded access. But one program survived that whole integration, and that was the DDD. So DDD has still remained as a waiver program within the Department of Health. It has not gone to managed care. Unless the client is not followed by a DDD case manager, maybe they didn't meet the criteria for that, then you have to look at if they have Medicaid, probably they have a service coordinator. So a good partner and a good person to team up with is their service coordinator from Ohana, or United Healthcare, Aloha Care, HMSA, or Kaiser. But often people have no clue who is their service coordinator. So you may have to start at that step, of finding out who is the service coordinator, because that's a very key person in care coordination. Because a lot of the things coming through Medicaid, you can get bathing services, you can get meals to the home, you can get a personal emergency response system. All of these home and community-based services needs to be approved by the service provider, the service coordinator.
Thank you for being so thorough and sharing your expertise as well as the community resources available for us to tap into with the DD branch. How about anybody else? Any comments? Case examples? Or are you like me that is just, I'm surprised I didn't know about this, because I know we have an aging population of people living with developmental disabilities and ID.
I could tell you some of the state efforts led in this. Most of the DDD clients are with a lot of Filipino physicians in Waipahu. A few physicians have majority of the clients. So we really targeted and we reached out to those doctors, and we had done a dinner in service, and we went through this in detail, because a few physicians have majority of their clients. So we wanted them to know about the scale, the stool, and to be familiar with it in case a case manager or a family member or caregiver brought this. We have done also a lot of outreach with Special Olympics and other waiver providers to get this out in the community.
Are you finding that the education that the care home operators are getting, the adult foster homes or other case managers, but especially the people that are doing the day-to-day care, Dr. Fernandez, do they feel better equipped to continue to care for these people as they age in place? And are they receptive like hospice care in that care home setting?
There lies the challenge is DDD's focus is how can we help them age in place and not move the client, because movement is a life stressor. It's not easy for us to move. Is not easy, and with this population, they lose their friends, they lose the caregivers they were familiar with. It's very, very hard. So more routine and structure is better. So there is a move on our state end to see if we can have more clinical expertise, and that's the new grant with the Catholic Charities is looking at getting national expertise, and we may have echo sessions just for this population, that we will have echo, and the hub team will be national experts, that we will have a neurologist, we'll have a physiatrist, and persons who are dealing with this population on a day-to-day basis. So that is something that we're looking forward in the next cycle. So congratulations to Catholic Charities. They were awarded an expansion grant from Administration on Community Living. So the next 3 years is going to build on this, what has already been done in the state, and try to get more expertise so we can get clients to age in place.
That's great. Do you have any data or information about how the neighbor islands are, those family caregivers and providers are being engaged with this training?
Yeah, whenever we've done all the past trainings, especially during the pandemic, whatever we did was on Zoom. And yes, the Arc of Maui was invited, or, a lot of the waiver providers have branches on other islands. So yes, we did have attendance from neighbor islands. We can go do some of the questions in the chat.
Yeah, there's another one from Melissa. What is the life expectancy and what is the average age that dementia is diagnosed in this population? Or is it on an individual basis?
Okay.
Thanks,
So,
Melissa.
The life expectancy has greatly increased. So I have another slide deck which will tell you in the 1920s and 1930s, they thought persons were going to only live till 18, till their 20s. They thought, doctors told families that this person will not live, just be a young adult and pass away. So in many families, you may find a secret. People never talked about that brother or that sister. It's very sad that families were told that their loved one will not live very long. But then you saw with all the advances in technology, in science and medicine, aspirin, antibiotics, our sanitation, our water, life expectancy increased. So it's now in the 60, 65 to 70. So they have a higher life expectancy than what was told, that they were going to pass away, most of them to their 18 and their 20s. So there is a increased life expectancy. And when is dementia diagnosed? Again, the delay in diagnosis is often the providers are not looking for it. So the diagnosis, like who's going to put it in the chart? It's the ICD-10 is coming from the medical diagnosis from a provider. If they get to a neurologist or they get to finally get diagnosed, it's often in their 40s or 50s. But we could probably diagnose that earlier if providers were aware, if we're capturing them in mid stage of dementia. So we're not capturing the early dementia in this population, and that's why there's a focus to do this early detection screen for dementia. So we can capture it earlier rather than a late stage. There's a question on blood levels and thyroid levels and blood markers. I do not know the data on that, especially whether thyroid or this, but I will tell you one thing that is a huge challenge. When I have had clients with DDID, I remember doing a home visit for a person with cerebral palsy in the Mayor Right housing, okay? Try do a blood test. It looked like we murdered the person. He was so upset. He banged his head, he yelled. It took him like 10, 15 minutes to calm down. it is, when you talk about this, especially to the caregivers and the, and the service providers, they start laughing at you because like, hey, Dr. Fernandez, good luck doing your blood test. And I've seen my own luck in giving a flu shot. It's not easy. It's really not easy to get labs and radiological stuff in this population. Thank you for your questions. I'm happy to answer other questions.
Judy, I just want to say that I really enjoyed your presentation. And also, I think the tool is great because, and I think if not only all caregivers could actually utilize it, it would help with their the person's physician, and help to plan and to see what is really going on at home versus the doctor who just sees the person maybe only for 15 minutes or a short period of time and doesn't have the whole history. So I think it's a really dynamic forum. Thank you for sharing and going through each page. Very helpful.
Thank you, Judy. We appreciate Catholic Charities has really championed this effort, and this training that will be coming up. I'm sure you will get the email notification about this. Just a heads up, it is November 1st, 2nd, and 3rd in Hawaii. I think we have a discounted fee. It's like $25, and there will be CMEs for this, and you'll get your C's right away because it's not coming from Queens. It'll be coming from NTG directly. So you will get CME credit for the training.
So Dr. Fernandez, where can people that are here today, if they wanted to see where's it going to be publicized so that they could register or get the flyer? They might have colleagues they want to share that training information with.
Okay, I'm just seeing if I can pull it up.
Okay.
I could put it in the chat.
Thank you.
Yeah.
I personally want to say I really appreciate that this is a population that's very marginalized. They have so many things, challenges, not just the physical challenges and mental health challenges, being DD or ID, but then you have to deal with aging challenges, right? And so it's important. It's a very important topic, and I appreciate that you and Catholic Charity and Judy continue to be champions for the people living with DD and ID.
Yeah, thank you, Sarah. We'll get it out to everybody. I'll ask John. John can send this. And one thing I didn't speak about is the caregivers. Please understand, like you said earlier, most of these are living with the adult parents. And most caregivers, when we think about it in our typical geriatric population, elderly population, a caregiver is doing 4 to 5 years of caregiving on an average, 3 to 5 years. But in the DDID population, the caregiving is a lifetime career. The parents are taking care of their disabled child for years. So please have a deep compassion for these caregivers. And they're very worried. What will happen to their disabled child after they pass away? Because you cannot assume that the brother or the sister is going to take them into their home. So every care plan, when we do care coordination, when we make our assessments and plan, let's remember that to, what are the long-term care options? When you discuss advanced care planning, it's something to discuss because these adult parents, they have that deep on their mind.
Yeah, I'm just going to add what you're saying is we have aging parents that not, yeah, again, they're caregivers, and as caregivers, we know they won't go and get their hip replaced, they won't get their knee replacement or hip replacement. They will put their health on the back burner because everything's about that adult son or daughter. Their whole life and their personhood is who that child is. And so they'll, yeah, it's very tragic. So thank you for reminding us to really not just have compassion, but try to understand the perspective and the context of what it's like to be a family caregiver, you know, for your adult DDID child that's also aging. Thank you, everyone. If there's no other comments, we've got 5 minutes left. This is your last chance. Take it or leave it. I see any other comments. No, thank you, John, for putting in the link for the CME evaluation as well. Any other comments, Rita Bell, before we sign off?
We will certainly follow up on the CE certificates. Thank you, Melissa, for bringing this to our attention. And we thank you for everybody for creating this community of learning. I know everyone is so busy with their clinical practice. Thank you for taking the time to join us on Geriatric Echo Clinic, and we'll see you next month. Aloha.
Thanks, Rita Bell. Thank you, John.